Good evening, everyone, and very special good morning to Dr. Carolyn April, who has taken this effort to address us this very early morning. And of course, she will be introduced and by our moderator of the day, Madam Bharti Reddy. She is I would say, the Queen of Chennai, who is very so well woven into the Mollywood, and we look forward to her gracious moderation. The topic today is of, I would say, immense importance to us, especially, I would say, in this country, because this whole issue of palliative care and the ethics associated with this particular thing is not so well understood, I think, by us all. And this is a kind of a problem which is going to be needing our attention more and more as the days go by. As our geriatric population is increasing, this problem is definitely on the increase, and we really look forward to learn from Dr. April.
A small introduction about Ms. Bharati Reddy. Srimati Bharati Reddy is the managing trustee and CEO of Vijaya Group of Hospitals. And this group encompasses Vijaya Hospital, Vijaya Health Center, Vijaya Heart Foundation, Vijaya Institute of Orthopedics and Traumatology, Vijaya Eye Foundation, and Vijaya Educational Academy. And Ms. Bharati is also instrumental in starting first private milk bank in Chennai, which is helping many thousands of newborn who are in need of mother's milk. And currently, Ms. Bharati is also the vice chairperson of CAHO Healthcare Division and very dynamic in promoting quality in healthcare. So now over to Ms. Bharati to welcome the speaker and moderate the session.
Thank you, Father Johnson, for your kind introduction. Good evening to one and all. I thank all the delegates and the CAHO members for taking their valuable time off to be present here in this webinar. Our topic today is on palliative care through CAHO Healthcare, CXO's Roundtable, which is an initiative of CAHO's Healthcare Division. I'm very proud and happy to be moderating this session on behalf of CAHO, a not-for-profit organization representing the healthcare industry, the diagnostic centers and quality professionals, with the main aim to promote patient safety and quality. Let me now introduce Dr. Carolyn April, who is our speaker of our session. Dr. April is an MD PhD, graduated with the highest distinction from Wheaton College in Massachusetts with a Bachelor of Arts degree in philosophy. As an American Rhodes Scholar, she completed her Doctor of Philosophy degree with a specialization in bioethics. From 2008 to 2012, she attended Harvard Medical School. She completed palliative medicine at Utah Health, San Antonio, Texas. She holds both certifications in internal medicine and hospice and palliative medicine. She's also a healthcare ethics consultant certified and a hospice medical director certified. She currently serves as a palliative care medical director and co-chairs the ethics committee at Penrose St. Francis Health Services in Colorado Springs. She is passionate about providing compassionate and ethical care for patients in any stage of serious illness. She focuses on the quality of life of both patients and families on multiple sectors: physical, psychosocial, and spiritual. Ethics in the end-of-life care plays a crucial role in critical areas such as diagnosis, the right to choose medications, and place of care. Dr. April is an expert in assessment of patients with advanced diseases, the relief of distressing symptoms, the coordination of interdisciplinary patient and family-centered care in diverse venues, the use of specialized care system, including hospice. With this short introduction, I invite Dr. April to share her views on palliative care, and I definitely believe this will be an eye-opener for all our healthcare friends in streamlining this service to the benefit of our population. Being a tertiary care CEO and trustee, I strongly understand the need of this care as we see enough patients who really require this service. I invite Dr. Carolyn April to take over this session. Thank you.
Thank you so much, Ms. Reddy. Thank you for the kind introduction. And thank you, Father Johnson, for the kind invitation. I'm very, very honored to be here today. Your organization sounds like an incredible group of people who are really committed to many of the things that I too hold dear. And I really look forward to sharing my experience with you about how palliative care is practiced in my particular American hospital. I am a physician at Penrose St. Francis Health Services, which is a community hospital system in Colorado Springs. I would say it's a fairly typical American community hospital. There are large academic centers, there are small rural critical access hospitals in America. It spans the spectrum for sure. And palliative care is practiced slightly differently in all of these settings, but I think a lot of the principles are generally the same. And I hope to introduce you to some of those today. So first of all, I just want to let you all know I have no financial conflicts to disclose. I will, during this talk, mention some palliative care resources, including a website that I am partial to called the Center to Advanced Palliative Care. And I don't receive any compensation for this organization. I'm not a part of its authorship. I simply find its resources to be extremely helpful in my own practice of palliative care. My team and I access this website probably on a daily basis, and it has been very, very helpful for us. So I'll tell you a little bit about that as well. I do want to just provide a few caveats and acknowledgements before we really get started. And the first is that I recognize that I practice medicine in a very unique and resource-rich environment in the United States. And I think our challenges are quite different from those which under-resourced nations face. And in general, my opinion is that American culture tends to place a very high priority on individualism. And our medical practice reflects that. Our medical practice tends to value very highly the idea of respecting individual patient autonomy. And many other countries and cultures do not emphasize individualism to the extent that Americans do. And I imagine that the way we do things might seem rather strange, but I just want to acknowledge that I am aware of that, and I think it does emphasize, or it does affect how we practice palliative care in the United States. Finally, I just want to make sure everybody knows I'm not a health policy expert or a global health expert. I'm simply an American practitioner of palliative care and medical ethics at the bedside. And I am here mainly to share how I practice, hopefully to stimulate some ideas among all of you about how do we expand palliative care to more people and more settings. So with that brief introduction, I will get started. I have a few aims today. I'm hoping to give you all a basic overview of what palliative care is. I imagine many of you are very familiar with palliative care and its principles, but for those of you for whom this is a newer concept, I'll try to go over some basic definitions and give you some examples of types of patients that my team and I are consulted to see. And then I'll go into a few of the details about how my team and I practice palliative care on a day-to-day basis in the context of the American hospital in which we work. I'll try to go through a couple of cases that I saw this week and explain the ways in which we try to alleviate suffering for these patients and their families. And finally, I'll close by introducing you and hopefully equipping you with a few resources to help stimulate the discussion and brainstorm some strategies so that we can work together to try to find ways to expand the reach of palliative care to more people in more settings across the world. And I hope that I will leave plenty of time for questions and comments, because I would really look forward to the discussion and to learning more about the challenges that you all face in your area. So to start, what is palliative care? I'll give you a very American definition first. Palliative care sees the person beyond the disease. It is a fundamental shift in healthcare delivery. Palliative care is specialized medical care for people living with a serious illness. This type of care is focused on providing relief from the symptoms and stress of the illness. The goal is to improve quality of life for both the patient and the family. Palliative care is provided by a specially trained team of doctors, nurses, and other specialists who work together with the patient's other doctors to provide an extra layer of support. Palliative care is based on the needs of the patient, not on the patient's prognosis. It is appropriate at any age and at any stage in a serious illness, and it can be provided along with curative treatment. And this is the definition that comes from the website I mentioned already, CAPSI. This is often how I will explain palliative care to patients and families when I first meet them. Even in American hospitals, a lot of patients and families have never really heard of palliative care and weren't aware that it is a medical specialty in the United States. And I usually, when I first meet patients and families, try to explain how we help. And I will give them a summary along these lines. The World Health Organization defines it much more simply. Palliative care is the active improvement in quality of life and relief of suffering for patients with incurable disease. Palliative care has really been recognized as a human right by both the World Health Organization and the United Nations, as well as the International Covenant for Economic and Social and Cultural Rights. Even though it's recognized as a human right by all of these organizations, of the over 40 million people in need of palliative care globally, estimates say about only 14% receive it. That may have improved in the years since this study was done, but there are many reasons why there are barriers to palliative care across the globe. Many physicians and nurses have never had training in palliative care and may not know the principles of evaluating and treating severe symptoms. There are access problems where the patients and organizations don't have the resources to provide this type of care to everybody who needs it. I think another barrier is the access to the medicines that are often used in palliative care, particularly opioids like morphine. Across the globe, many cultures and organizations are understandably very concerned about the addiction potential of opioids. And of course, we in the United States have a terrible problem with the opioid epidemic. So I understand why people are nervous about it. But just like any powerful tool, opioids have both good and bad uses, and we rely on them a great deal in palliative care, and they help us relieve a lot of suffering. So I do think that that lack of access to opioids makes it very difficult to do good palliative care across the world. So there are many barriers. One of the things that I try to explain to patients and to physicians in training when I'm teaching them about palliative care is I think a lot of people harbor some myths about palliative care, particularly in the American context. One of the myths is this. There's an idea in American medicine, at least this was the idea of several years ago, that when a patient would present with serious illness, the doctors should first focus on this red rectangle where we aim all of the therapies at trying to modify and treat and slow the progression of the disease. And only when we run out of all of those options at a very clear-cut line, then do we switch to this blue rectangle where we focus on therapies to relieve suffering and improve quality of life. And we call that focus of care, palliative care or hospice, and kind of use those words interchangeably as though palliative care and hospice are the same thing. And that's what we do in the lead up to the patient's death. I think this is an oversimplified and misunderstood way of thinking about palliative care. So when I'm teaching American physicians in training, I show them that actually the reality looks more like this. When a patient initially presents with serious illness, yes, of course, we will still try to use therapies to treat and modify their underlying disease, try to slow the progression of their cancer, for example, or consider advanced therapies like dialysis for end-stage renal failure. But they can still have palliative care at the same time. And if they are having symptoms related to their disease, we can still help relieve those symptoms even as we're actively trying to treat the disease. We can still support the patient and family in all of the domains of their suffering. And as the disease progresses, as all diseases eventually do, and we reach the point where maybe the therapies to modify and treat the underlying disease are becoming too burdensome for the patient, that's when we might consider a shift to a very specialized type of palliative care called hospice, where the entire focus of the care becomes focused on alleviating the suffering of the patient rather than treating the underlying disease. And that even after death, the hospice palliative care team will continue to provide bereavement support to the family and support them in moving past the death of their loved one. I want to emphasize that there are really two types of palliative care. The first is what we call primary palliative care, and this is the really basic palliative care that really all clinicians, regardless of their specialty, should be able to provide to their patients. Very basic symptom management skills and basic skills in communicating with patients and families about serious illness. I believe that all clinicians should have at least basic skills in this area. And that's what we call primary palliative care. However, there is also specialty palliative care, which is what I do. And this is the type of palliative care that is provided by a specially trained interdisciplinary team, the members of which have expert training, such as fellowship training in palliative care. And this type of specialty care is most appropriate for those patients who have very complex palliative care needs. So I wanted to, before going on to the next section, I wanted to just give you all a couple of examples of patients that our team was asked to see just this week, just to give you a sense of what types of patients in the hospital we are being called to consult on. This first one, I just saw this gentleman yesterday. He is a 55-year-old man. He has been newly diagnosed with metastatic colon cancer. He is having a lot of uncontrolled cancer-related pain in his abdomen, and he's having a lot of anxiety related to the diagnosis. So his hospital doctor called our team and asked if we could see him and provide palliative care. We also were asked to see this woman. She's 89 years old. She has chronic and incurable gastric outlet obstruction. She is sadly slowly starving to death because of this obstruction, and she's not particularly interested in having any more surgeries directed at this problem. So we were called to see what we could do to help her. I also saw this gentleman. He's a 92-year-old man. He has advanced dementia, lives at home with his son and his daughter-in-law. Can barely walk or manage any of his basic daily needs, such as toileting and showering on his own. And he suffered an acute stroke and was admitted to the hospital, was found to have hemiplegia. He's become completely bedbound. And due to the stroke, he has severe dysphagia and is unable to swallow any food or medicines. So those are an example of some of the patients and the patient types that we're asked to see. And I'll ask you to keep those in mind because we'll address them in this next section. So moving on to how do we go about practicing palliative care in our particular American hospital? Our specialty palliative care team is very much team-based. We have an entire team and we are made up of many disciplines. And our team has about 10 people total for a 700-bed hospital system. And each discipline on the team is responsible for evaluating and addressing different domains of patient and family suffering. So for example, as a physician, my domain focuses mainly on evaluating serious physical symptoms and mental health symptoms and prescribing medicines or other interventions to try to reduce these burdensome symptoms such as pain, shortness of breath, anxiety, fatigue, the list goes on. And my other primary role is to conduct complex discussions with patients and families to help them understand the nature of the illness and the treatment options, and to elicit the patient's preferences for their care so that I can offer recommendations for medical treatment plans that really fit their goals and have some chance of achieving their goals. We have a nurse on our team. She is responsible for helping us coordinate the care of the patients. She does a lot of empathetic listening at the bedside and providing support to patients and families. And when we are caring for dying patients in the hospital, she is often the one to attend to them at the bedside to make sure that medications are being administered to bring comfort and to support the patient and the family throughout that transition process. We also have a social worker, and her focus is on assessing the psychosocial distress that can accompany serious illness. And she helps identify where the patients and families are struggling, if they're having financial difficulties or family dynamic problems or caregiving burden. And she helps to identify resources out in the community to help provide support to help with those sources of suffering. And of course, we also work very closely with our hospital chaplains. We consider them a part of our team. In many palliative care teams across the United States, there are particular chaplains dedicated just to the palliative care team. And we absolutely must have hospital chaplains because they help us assess and attend to the spiritual distress that many patients and families experience when they're facing very serious and potentially life-limiting illness. So our chaplains are a key part of the team as well. In our practice in the hospital, there are really two separate but related domains for consultation, two main reasons that the hospital doctor will call our team and ask for help. The first focuses on symptom management needs. So the primary hospital doctor might call our team because that doctor recognizes that the patient or family is having various sources of suffering, and they would like our team to help manage these sources of suffering. So we went over some of these already, but there's domains of physical suffering, like physical symptoms, pain, shortness of breath, anxiety, depression. The spiritual suffering, such as the guilt or regret or unfinished business that patients might feel as they're facing a serious illness. And of course, all of the psychosocial worries like financial concerns and caregiver distress that I mentioned. So this symptom management is one domain for which we are often called to try to help. The other domain we tend to call goals of care. And this is where, a hospital doctor starts to recognize that the illness is becoming very complex, the treatment options might become very burdensome, and they might be asking for our team's help to sit down with the patient and family to try to elicit what are their top values and priorities, to help them weigh the benefit versus the burden of further disease-directed medical interventions, and to try to discern the patient and family wishes regarding things such as whether to attempt cardiopulmonary resuscitation. So these are really the two main domains for which the hospital doctors will call us to try to help with patients. So when a doctor calls, he or she might say, hey, Carolyn, I've got a patient who's got a lot of bad symptoms from their disease. Can you come and help? Or they might say, you know, this patient and family really needs help with their goals of care. Can you assist? Or they might ask us to do both. So those are usually the reasons why we get involved in a patient's care in the hospital setting. I just want to pause here for another very brief caveat relating to that goals of care domain. So I recognize in my very resource-rich country, we have an abundance of medical technology. We have lots of treatment options for advanced diseases like cancer and renal failure and heart problems. And for those patients in America who have access to care, and it's not all of them, but for those who do, in the hospital setting, we rarely worry, are we doing too little treatment for the patient? Instead, of late in the last decades, we've started to worry that maybe our technology is outpacing our ethical practice. And we worry more that maybe we are doing too much medical intervention, that perhaps we're doing too many invasive or burdensome medical treatments that really have no hope of cure and that have very little chance of improving a patient's quality of life. This is very much a champagne problem. You know, we have all of these incredible technologies, which many resource-poor nations lack. And but it has caused a different type of challenge in our setting. And our palliative team is often on the front lines of trying to navigate this ethical challenge in medical care. So I just want to acknowledge that we're often consulted to talk about this very worry with the patient and their family, and to really try to discern what their goals are and which treatments might help. It's very much a conversation in which the patient, if they have the capacity to share their thoughts, we try to give them a very strong voice in the direction of their care, and talk about which treatments they think might help achieve their goals and which treatments should maybe be avoided because they're too burdensome. And I recognize that this approach is a very uniquely American approach to care that really focuses a lot on that individualism streak that runs through our culture. And this may seem like a rather unusual concept to folks in other countries or who come from different cultural backgrounds. So I just want to make sure that I acknowledge that. All right, so moving on to returning to those three patients that I mentioned, just to go through each of them very briefly and give you an example of how our team worked to try to alleviate their suffering. So for that first gentleman, this 55-year-old man, he was newly diagnosed with this metastatic colon cancer. He's in the hospital. He had a surgery to try to remove the part of the cancer that was causing a bowel obstruction. And he has become so debilitated, it's hard for him to eat. He's having a lot of pain. He's very much alone in the world. He's estranged from his family, doesn't have a spouse or children or any close friends. And he is having a great deal of anxiety related to his diagnosis. So the first day that I met him, I spent about an hour sitting with him and talking about his journey and his life and how did we get to this point? Who are the people in his family? What are his sources of support? And then focusing a lot of our attention on evaluating his symptoms, trying to figure out what type of pain he was having, how severe it was, which treatments were helping and which were not, and educating him about how I wanted to try to get some of these symptoms under control. So one of the first things I did for him was to prescribe some sublingual and IV morphine to try to get his pain under better control. Yesterday, I started him on a medication called dronabinol, which is synthetic THC, similar to marijuana, to try to help with his nausea and his anxiety and his anorexia. I also started him on a medication called olanzapine to try to help with the same symptoms. And I also contacted our chaplain and let that person know that this man really needs some support, to help address his loneliness and his fear of the diagnosis. So we worked together as a team to try to help support him in those symptoms. The second patient I mentioned, this is an 89-year-old woman. She is sharp as a tack. She retains all of her cognitive faculties. And she's been dealing with a chronic and incurable gastric outlet obstruction for many months and has been admitted to the hospital many times with complications of this. And it's to the point that she can't really eat anything anymore because she just vomits it up. It's very, very sad. And she seems to recognize what's happening to her. And she is not particularly interested in having any more surgeries. But her daughter, who's her primary caregiver, is more interested in surgeries. And so our team was consulted to try to help navigate what do we do to come up with a good medical plan for this patient. And yesterday, our team had an extensive, hours-long meeting with the patient and her daughter. And our focus was really trying to elicit the patient's top priorities. We kept asking her, what is most important to you at this stage of your life and of your illness? And the patient was able to tell us that what was most important to her is staying comfortable and dying peacefully, hopefully at home, whenever the time comes. And so given those goals, we recommended some courses of action. And one of the things we did was discuss the patient's code status. We asked her, if that time of death comes when you're in the hospital, and if your heart stops and your breathing stops, how would you want us to handle that situation? It doesn't seem like putting you through an aggressive resuscitation attempt with chest compressions or putting you on a breathing machine would really keep you comfortable or help you get home. And she agreed, and she decided against any attempts at resuscitation. She chose to have a do not resuscitate or a DNR code status, and our team helped coordinate the care to make sure that that wish of hers continues to be respected while she's in the hospital getting our treatments. And then for our third patient example, this is a 92-year-old gentleman with advanced dementia. He suffered the acute stroke and is now hemiplegic and bedbound and can't speak and can't swallow. And since he no longer has the capacity to make and express his own decisions, we met with his son, who happens to be his medical power of attorney. And we met to discuss the diagnosis and try to elicit the most important goals. And the son has a good understanding of the illness. And he said, what's most important for my dad is to be comfortable for whatever time is left, to have a peaceful death whenever that time comes, and to really avoid any invasive things that might cause discomfort or prolong the dying process, like a feeding tube. So knowing that, we recommended to the son that we take what we call in America a comfort care approach. This means we acknowledge that the disease is likely going to follow its natural course and will result in death. And instead of, treating the disease itself and putting the patient through a lot of procedures that are not going to cure the problem, instead we focus on allowing the disease to take its natural course. We acknowledge that this is going to result in death at some point, but we treat any symptoms that arise, like pain or shortness of breath. We treat those symptoms very aggressively with medications and other non-pharmacological interventions to try to alleviate suffering. We give morphine for pain and air hunger. We give lorazepam when the patient gets anxious or has delirium. And we talked with our social worker on the team, and she enrolled the patient with a hospice service. And we were able to discharge him from the hospital to respite care in a hospice house where he will receive comfort care for weeks until he dies from the complications of his acute stroke. And this plan of care brought a lot of comfort to the son, knowing that his dad's wishes at the end of life would be respected. So moving on to just briefly mention a few resources to try to brainstorm ways to help expand the reach of palliative care in other settings. I've got a few articles here. I attached those when I sent the slides, so hopefully those will be distributed. I read through these last night. They're fascinating. This is one about the value of palliative care provision in low resource settings. And there's another one about the global state of palliative care and some progresses and challenges, particularly in the area of cancer care. This one I found the most interesting. This is on the perilous state of palliative care in the developing world. And reading through this gave me actually a lot of hope, because it mentions a success story in the making, actually taking place in India. The author mentions that Kerala in southern India now has about 2/3 of the country's 300 palliative care centers. That there has been collaboration in that state between the state and non-governmental organizations, healthcare professionals, and volunteers. And since 1993, groups there have been able to use a small government grant to train healthcare workers and volunteers to set up a community palliative care center. And they've become one of the first states to change some of the drug regulations to help make morphine more accessible for patients at the end of life who are suffering and who really need this medicine. And in 2008, they became the first Indian state to adopt a comprehensive policy for palliative care. So that story really gives me a lot of hope that for people who are passionate about this type of care, coming together, there are ways to help expand this type of care all across the world for people who need it. I also wanted to share some resources that might be more applicable to our American context, but I think that they can really help anybody who is interested in palliative care, regardless of what setting they practice in. This is the Center to Advance Palliative Care. It's available at this website, and it's a tool to help provide training and assistance and connection for all clinicians who are caring for people with a serious illness. And I've just got a few screenshots here of the website. The website itself is free, and people can access it without an account. And there are a lot of resources on here that are free. There are some tools that help demonstrate the value of palliative care to hospital executives and care organizations. There are blueprints for how to train a workforce and how to expand access to palliative care. And there are also clinical training opportunities on this website. Most of these require a subscription to the service. And our organization where I work, Centura Health, has an institutional subscription to CAPC. And it's just a wonderful resource, because every person in our organization, whether they're physicians or nurses or social workers, every person can use our Centura email address to log into CAPC for free and do any of these online courses to help us improve our palliative care skills. And to just show you a few examples of the training modules that they have. There's a set of training modules in pain management, and going through these 14 courses, you can receive CAPC designation as an expert in pain management. It covers, which patients are appropriate to consider for opioid therapy. How do you assess risk for substance use disorder? How do you safely prescribe medications like morphine? How do you dose them? How do you monitor? These are all courses that a person can do anywhere that they have access to an internet connection. So for anybody who is interested in learning more about how to dose morphine or titrate it to effect, this is a great resource. There's also a module on managing other symptoms like shortness of breath and anxiety, depression, delirium. A lot of really helpful modules for figuring out how to evaluate and approach managing these symptoms that cause a lot of suffering. There are modules on communication skills. There are, going through these modules helps clinicians learn how to talk with patients and families who are facing serious illness. how to discuss their hopes and their fears, how to elicit their goals and their preferences for treatment, how to make gentle recommendations about what medical treatment plan is going to best honor their priorities. There's a lot of really difficult communication skills that we have to learn as clinicians, and CAPC has some wonderful modules to teach us about that. There are also disease-specific modules, such as caring for patients with dementia. As we mentioned in the introduction, there are the aging population across the globe. Dementia strikes people everywhere, in every culture, in every nation, and it is an incredibly burdensome disease, not only for the patient, but for the caregivers and the family and the society. And these modules really help go over best practices in dementia care and how to provide good caregiver support. So they can be very, very helpful, and I find them useful. I do these modules almost every weekend just to refresh my skills. So I would definitely encourage checking that out. So in summary, I hope I've been able to provide an overview for you of what palliative care is. I'm sorry, I think there's an alarm going off in my kitchen. Give me one moment and I'll stop that sound. I'm so sorry. I apologize. That's what happens when my kids leave their cell phone on the counter. Anyway, I also hope I've explained how my team and I practice palliative care in the context of our American hospital on a day-to-day basis. And I hope I've given you all some ideas and equipped you with a few resources to start to brainstorm strategies to help expand the reach of palliative care to more people in more settings across the globe, really. And just to share some final thoughts, I think these two quotes really sum up palliative care for me. This first one from Harvey Cushing: "A physician is obligated to consider more than a diseased organ, more even than the whole man. He must view the man in his world." And it is that whole person approach, that meeting a person where they are in their family context, in their cultural context, in the context of their disease. That is the essence of how we practice palliative care. And finally, this is one of my favorite quotes about the purpose of medicine from Dr. William Osler. "Our aim is to cure sometimes, to relieve often, and to comfort always." Thank you so much for your attention, and I welcome any questions or comments that you might have.
There are a few question and answers over here, and questions. I think somebody is asking. Question is eager to know what kind of technology we are using in palliative care for doctors, nurses, and the healthcare workers.
What kind of technologies that we're using, like to provide treatments or to learn about palliative care?
Yes.
I see. So we use technology to learn about palliative care. You know,
tools and techniques. I think that's what they were asking. Tools and techniques.
Tools and techniques. Yes. So I would say we use a lot of pharmacological technologies. We use a lot of medications because these tend to be less burdensome for patients than interventions like surgeries and procedures. So we use a lot of pharmacological advances with opioids and anti-nausea medications, but we do use some interventions. Some patients have very complex cancer-related pain. We often will consult our interventional pain specialists to do things like nerve ablations or nerve blocks. We will sometimes make use of epidural technology to provide treatment for severe cancer-related pain in certain areas of the body. We will sometimes use palliative measures to try to relieve the symptoms of severe illness. So for example, if a patient has a malignant bowel obstruction and they know that there's nothing we can do to relieve the obstruction surgically, but they just want to be able to eat and drink for pleasure, sometimes we will ask our gastroenterology colleagues or our surgery colleagues to place a feeding tube in the stomach, not for the purposes of putting food in, but rather for the purposes of venting the secretions out. And that allows patients to eat and drink for pleasure, and it gives them a way to relieve the pressure, and it helps improve quality of life. Sometimes we'll do palliative stenting of various obstructed organs to try to help improve a patient's quality of life, even though we recognize that the stenting procedures for a blocked bile duct or a blocked intestine from cancer or a blocked bronchus from a lung cancer, we know those things are not going to cure the disease, but they help improve the patient's symptoms and may even prolong their life. So those are some examples of the technologies that we will make use of in palliative care.
Thank you very much. I think there's another question that the primary consultant wants to shift the patient to the palliative care team, but the patient refuses because their confidence lies with the primary consultant. How do we handle such a situation?
Yes, we face this situation a lot in our context as well, and
I'm sure.
different centers will handle it differently. Some American hospitals and communities will have palliative care teams that manage patients primarily, and they will become the primary team and take over the care of the patient. Others, like our team, serve only in a consultation manner, and so we never take over the primary care of the patient. We continue to act in an advisory capacity, and we ask the primary team to continue to see the patient and be involved so that the patient doesn't feel abandoned. In the outpatient setting, when patients elect to enroll in hospice care, most of them have the option to either have the hospice team take over the care, but if they have a real connection to their primary care physician and don't want to feel abandoned, the Medicare hospice benefit still pays for the patient to be able to go see their primary care doctor, and the patient can elect to have their primary care doctor as the attending of record even when they're on hospice. So we recognize that patients often form very deep relationships with their primary teams, and being involved and being on palliative care and even being on hospice doesn't mean that those relationships have to be severed.
Thank you, Dr. April.
Dr. April, you did an excellent job. Excellent job. It was very, very informative, very, very inspiring. I think the number of questions that come up is the best proof that you touched their hearts. Yes. So thank you so much, for that. I also like to say a word of thanks to Father Abraham. In fact, Dr. April was not known to me. Father Abraham is my batchmate, and only Father Abraham told me that we have an excellent resource person. And Abraham, you said it right. We all feel that. So thank you, Father Abraham. Then Dr. Ms. Bharati Reddy, thank you for moderating this session. So thank you for all the participants.